Good morning, good afternoon, and good evening to everyone tuning in from all across the world. This is Justin Moore from Moberg Analytics, and welcome to our monthly webinar series where we go through case studies in neurocritical care, clinical uses of machine learning, and talk about all kinds of cutting-edge research that's being done to advance the field of neurocritical care. Part of the reason we do this webinar series is because we know that understanding and treating brain injury is a really difficult problem, and it requires a lot of collaboration. Our goal as a company is to help you in that mission by providing tools and products, but also this webinar series where we bring talented minds together and showcase the amazing work that's being done all across the world to push the boundaries and change the way we understand brain injury. Our episodes showcase the work of researchers, case studies that demonstrate their work, and tutorials on how you can use the methods and models that they present for yourself. We always want to improve these talks, so afterwards, please leave us some feedback. And if you have suggestions for a topic, a novel, upcoming aspect of neurocritical care, you can fill out the form and tell us about it. If it's your research and you or a colleague would like a platform to speak about it, you could even volunteer yourself for the hot seat. You can scan the QR code to access the feedback form, or if you'd like to use your browser, you can go to the shortened link bit.ly/Moberg webinar feedback, or by sending our CTO Craig an email. That's craig@moberganalytics.com. Don't hesitate to reach out. We'd love to hear about your work and give you a platform to share your findings. If this is your first time watching, you can find the previous episodes on our website at moberganalytics.com/webinar or on our YouTube channel, Moberg Analytics. Last but not least, if you have any questions during the webinar, please leave them in the Q&A section by opening up the Zoom menu at the bottom of the screen. I'll be able to see your questions and then forward them to the speakers. Speaking of which, today we have a very special guest, Dr. Jed Hartings. Dr. Hartings' research is focused on understanding the role of spreading depolarizations, or SDs, in both the development and treatment of secondary damage after traumatic brain injury. He is a co-founder of the Co-Operative Studies on Brain Injury Depolarizations organization, also known as COSBID, which has pioneered the study and characterization of SDs in the human brain for 20 years. Dr. Hartings graduated from the University of Notre Dame and earned his doctorate in neuroscience at the University of Pittsburgh. He then studied brain injury at the Walter Reed Army Institute of Research for 8 years as a U.S. Army officer, separating from the service at the rank of major. In 2008, he joined the Department of Neurosurgery at University of Cincinnati College of Medicine, where he is now a tenured professor. His work with COSBID as a translational neuroscientist has contributed extensively to the current understanding of SDs as a mechanism of lesion development in cerebral gray matter, and his clinical work, leading several multicenter studies, has shown that SDs are independently associated with worse patient outcomes. His work suggests that monitoring and treating SDs in the clinic could be an effective strategy to improve both patient survival and recovery from severe brain trauma. That's a huge deal, Dr. Hartings. And something I want to know is if monitoring and treating SDs really contributes so much to patient survival and recovery, so that sounds like something we want to do, right? Is this already a standard in neurocritical care, or is this something that no one's doing?
Well, it's I'll touch on that briefly in the talk, but we're not we don't yet have randomized clinical trials that have tested the idea that monitoring and treating can improve outcomes. But we are conducting those trials now, so stay tuned. But it's definitely something that's being adopted more and more widely for routine clinical care, despite the fact that we don't have, highest level randomized controlled trial evidence that it does improve outcomes.
Sure, yeah, and I don't want to get too much into the talk or step on your presentation, but I'm curious, what does the monitoring or treatment or therapy involve? And are there barriers to intervention at the bedside?
Yeah, and really that's what this seminar is going to address, is trying to tackle one of those big barriers, which is really just the manpower and expertise required to read rather complicated new neuromonitoring data feed, which is ECOG, because it's not something that's part of the neurophysiologist's clinical neurophysiology training. So if we can automate that, then it would really allow for more widespread adoption. Having the available hardware and other, tools to make the recordings was a major barrier for a long time, and that was solved thankfully with the Moberg device and the modified advanced amplifiers. We shout out to Moberg for being great partners to COSBID and to myself and others in bringing this science forward. Your introduction of, your goal to help science, that's not just a tagline. It's something you guys do. You have a track record, and we're grateful as a community.
Absolutely. Yeah. Thank you so much for shouting out our company. If you're ready to go, I can turn it over to you and you can get started.
Yeah, sure. Let me share my screen if I can. Okay, are we good? If
Yep,
we're
I
good,
can see
then,
your screen.
okay, super. Then, well, thank you again for this opportunity. What I'll talk about today is some work that I've been doing over the past few years with a graduate student in computer science, Sreekar Puchala, who is also with us here today. This work has been the majority of his dissertation, his doctoral thesis. So I'm very proud of the work that he's made and the progress and the relevance to real world applications that this project engenders. The first paper was published just a couple months ago in Scientific Reports. So anyone who's interested can go to that reference to find the details that will necessarily have to omit today. So I think most people on the call, probably if you dialed in, you're already interested in spreading depolarizations and have some knowledge of what they are. But they've been known about for 80 years, and the work of the last 30, 40 years has really shown them to be a required and causal mechanism for developing acute pan-necrotic lesions in cerebral gray matter, such as the infarcts you see after a subarachnoid hemorrhage or in stroke. And what's particularly exciting and motivating for me as an SD researcher to get into and stay in this field is how it's something that can be studied in all kinds of animal and laboratory systems, down to the level of single ion channels and organelles and electron microscopy. And now with the clinical translation, being able to monitor this in patients, we can really understand better understand a mechanism from organelles all the way to patient outcomes. So this is just such a rich field for translational science that makes it very exciting. And anyone who needs a reference, I'm going to shout out to Andrew Carlson, who just published a really nice review article in Neurosurgery at the end of last year. So with patients in the clinic, we monitor spreading depolarizations with the same method that was developed in 2002 and earlier by Tony Strong in London, which is to place a linear 6-electrode strip in the subdural space directly on the brain in patients who require neurosurgery for aneurysm clipping or for decompressive craniectomy after trauma or after malignant hemispheric stroke. So that electrode strip can get connected to the Moberg advanced amplifier, and we can do continuous monitoring and recording of brain ECOG activity over the course of a week, even 2 weeks, to look for spreading depolarizations. And using that technique, we get these sorts of beautiful images that we can see to inform our care of the patients. What you see here is the recordings from those 6 electrodes on a strip, and you see one SD wave beautifully propagating from one electrode to the next, all the way across the strip from the point of injury into, or the point of the developing lesion or hematoma into the adjacent brain areas. And what we've learned from doing this over the past 20 years is, in observational research, is that SDs are associated with worse outcomes. And these are just some figures from one of our recent papers showing that of all the patients that we monitor to go for surgery after a traumatic brain injury, about a third of them have this really severe adverse course of repetitive SDs that often develop into isoelectricity of the brain. And patients that have those patterns independently, this is a prognostic factor for worse outcomes, with odds ratios somewhere above 2 for a worse outcome, independent of other variables. Similarly, work that's been conducted by Jens Dreyer's group in Berlin over the past 15 years. It was just published in 2022 and 23, which is really exciting. Essentially shows the same thing, that SDs are predictive of worse outcomes. And moreover, through a really detailed study design, a very rigorous study design, he was able to actually test the translational hypothesis that SDs are the mediators between the toxic effects of subarachnoid hemorrhage and the development of delayed cerebral infarcts. So this was really powerful analysis that resolved the longstanding questions in the field of vasospasm research, relating to the fact that the diagnosis of vasospasm is not very predictive of delayed cerebral infarcts. And his work has shown that SDs are partly responsible. So these results have all provoked a lot of interest in SDs, and the question for a long time is, well, that's really interesting, but if we can't do anything about it, it's not clinically useful. Well, we know now as well that we can do something to treat spreading depolarizations. The first line of defense as an abortive treatment is the administration of NMDA receptor antagonists, such as ketamine. And this is just one patient example, a subdural hematoma patient who had recurring SDs every 20 minutes, for a period of several days. And when the patient was given a bolus of ketamine for other reasons, we could see the SDs abruptly stop for a period of maybe an hour or two until the ketamine wore off and the SDs returned. But there are now dozens of papers, way too many to cite, evidencing the efficacy of ketamine, which is now without question an effective treatment. There are also physiologic risk factors that contribute to the development of spreading depolarizations as a brain pathology. And these are the types of variables that neurointensivists are typically interested in monitoring and controlling for therapeutic benefit, such as the blood pressure and the temperature, which all contribute to spreading depolarization risk, which brings this type of pathology even more into the realm of clinical interest and clinical relevance. So there are, to answer the question posed at the beginning of the hour, there are more and more centers adopting this methodology with the increasingly known clinical applications. And as I mentioned as well, we are now in the middle of conducting the first randomized interventional trial to determine whether or not guiding clinical care through the use of ECOG monitoring of spreading depolarizations provides patient benefit. And we're at about 50% of our targeted enrollment, so that's very exciting. But one of the barriers, as we mentioned, to the broader clinical adoption is that scoring SDs in these recordings requires a high degree of specialization, with differences in the hardware required, the software required, some understanding of signal processing, and very different data displays in terms of amplitudes and time scales. as compared to standard other clinical neurophysiology. And so as a result, neurophysiologists simply aren't trained to recognize SDs. And apart from the occasional webinar or workshop, there are really no courses that teach SD scoring. And even after someone has gone through a didactic course in theory about how to recognize these events, you still need a lot of practical experience reviewing dozens and dozens of patient data to really gain the experience necessary to be able to put that didactic learning into into effect. But there are really no databases out there to gain that experience. It's rather difficult. And furthermore, even if there is someone trained and able to do the readings, it is very time and resource intensive. So we thought that one potential solution for this would be, or at least a partial solution, would be to develop an automated method for SD detection. And already, there's been one example of this. The London group has developed their own automated detection software, which was published a few years ago. And we have used this, and it does work well. So kudos to Tony Strong's group for continuing to lead the way. But we were motivated to develop our own automated detection routine as part of a broader effort to develop software that is purpose-built and customized for the review, scoring, and quantification of SDs. Since detection of SDs kind of goes hand in hand with measuring and studying the waveforms, which was our interest. And in development of this software and for the automated detection efforts, let me briefly orient you to some of the display conventions that we're using here, because there are several different options for data processing and display. But these are the ones that we use, which are to display data as monopolar recordings as opposed to bipolar, monopolar being against an extracranial reference electrode. What we then do is we split the data stream from each monopolar channel using with a bandpass filter for one of the data streams to display the higher frequency activities at 0.5 hertz and above, for instance, in the typical neurophysiology band. And those are the colored traces here in a highly time compressed display with 5 minutes per division here. And then the other data stream is for the slow potential display, which are the ones overlaid shown in white here. And these are baseline corrected to correct the DC offset by subtracting a 30-minute moving median average, or moving median. And I'll illustrate that in a moment. But those are our preferred methods. And to understand our approach to automated detection of these events, it's important to understand that there are 4 criteria that are typically used to recognize SD. The first is the negative direct current shift or slow potential change that occurs, as you can see here in the white traces propagating across the electrode strip. Second is the depression of the spontaneous activity, which you can see here in purple and then green, and it propagates along with the DC shift. Thirdly, there's the spread, typically at a rate between 1 to 9 millimeters per minute. And then fourthly is sort of the stereotypical recurrence of these waveforms. And just to illustrate what that kind of looks like, and this is particularly helpful when the waveforms are atypical or a little bit borderline, you're not sure if it's an SD or not. If you see it repeat in a stereotype pattern, that can help increase your confidence that these are SDs. And so here's an example of 3 different SDs propagating from electrode 2 to 4 from the same patient. You can see that each channel, just as every patient and every channel and every patient has its sort of unique appearance. And sometimes that even changes and evolves through time. This is kind of a neat method of data display where we've got about 9 hours of data here with the DC shifts of each SD occurring in each electrode, so you can kind of see the gestalt pattern. And here early in this trace, we see sort of this pattern with electrode 2 and 3 leading together with 5 and 6, and then they sort of converge on electrode 4 through time. But then later in the course, there's a different pattern that emerges with them starting at 2 and then spreading out towards either end of the strip. But you can see in both cases, there's a stereotyped pattern specific to the electrode and specific to that particular time in a patient's recording. So typically, in research and clinical care, our method of scoring SDs is to count the number of unique waves, considering the entire electrode strip. So in these examples that I've shown, we can look at these individual events and individual channels and just kind of refer to these as events. But it's all of them together that constitute a single SD wave, which we might also call a super event. So in the data that I have displayed here, there are 2 SDs as opposed to 12, but there are 12 waveforms. So in contrast to the typical approach that I just explained in manual scoring, which uses all the information from all the 4 criteria and across all the channels to identify these super event SD waves, we took kind of the opposite minimalist approach to ask the question to see if we could use the least information possible to identify the individual events. That is, to detect the individual DC shifts of SDs in individual channels, and to do so using only the sparsest data possible at 0.1 hertz, so 1 sample per 10 seconds. So we challenged ourselves to do this and to completely ignore the depression of spontaneous activity, completely ignore the propagation patterns and any sort of interchannel information, and to ignore stereotypic repetition as criteria. If we can do that in phase 1, then maybe in phase 2, we can use additional data to enhance the accuracy of event detection, and then also identify the super wave events or the super events. So just to kind of illustrate again how this approach is different, this is the clinical approach to count the 1 SD wave based on using all of the information available here. And there's a great degree of redundancy because you could delete a lot of this data and still be able to recognize that, yes, there's a unique SD wave, a new unique SD wave happening here. So what we've done is stripped away all the high frequency data, and then we've stripped away all the channel information and all of the relative timing information to see if we can just detect these individual waveforms. And then we further strip away the resolution, even within these individual traces, by downsampling to 1 data point per 10 seconds. So our approach then was to use a supervised machine learning algorithms and see if we can train them to distinguish positive from negative SD sample waveforms. And for this purpose, we used over 1,100 hours of 6-channel data from 14 different patients, TBI patients. We used expert manual scoring of over 1,500 unique SD waveforms to serve as the positive examples to train the model, and we used all the remaining data as the negative samples. We used 2 different machine learning algorithms, support vector machine and extreme gradient boosting. And for each of the samples, we extracted up to 80 features in both time and frequency domains as input to feed into the model for the classification. And then we trained and tested the model using the leave 1 patient out cross-validation. So we would train the model on 13 patients and then test it on the 14th. And then we'd go on to the next patient, leave him out, train it on the others, and then test it on that patient iteratively. And to prepare the samples, we started with the raw ECOG. And then we did this baseline correction, which is the subtraction of a moving median filter. And that's illustrated here, and the reason and the effects. So the top trace here, this is a raw signal, complete with the DC offset of like 70 millivolts. And then you see this big drift of about 20 millivolts, which really distorts this SD waveform, the one shown here in red, so that you really can't see it too reliably. And so to make the appearance of all these a little bit more uniform and correct these artifacts, we calculate the moving median, subtract that from the original signal to get a baseline corrected signal, which now, as shown in black here, looks a lot more like a normal ST. So we apply the baseline correction, we low pass filter, we downsample to 0.1, and then we extract a sample that's between 400 and up to 1,000 seconds long. And this is just a summary that shows what these typical positive sample DC waveforms look like. On the left, this is just the DC shift corrected waveform without the moving median filter. And by comparing that to the moving median filter waveform, you can see that really that moving median filter or baseline correction doesn't impact the waveform of the SD at all. The average waveform is the same duration, the same amplitude. So we really consider it a superior method for zeroing out the trace and for baseline correction. We ended up removing about 300 of these waveforms due to the presence of really large amplitude artifact, as can be seen here in this red trace, just to have a bit of a cleaner data set of positive examples for training the algorithm. So we went ahead and we tested these two methods of machine learning, SVM and XGB, using a standard measure for performance, which is the F1 measure based on precision and recall of classification. And we experimented with different feature counts and with different window lengths to see what would give us the optimal performance. And so just focusing on the feature counts, as we increased to about 30, we started to reach a plateau in the overall performance level in the F1 measure of 0.88. So we thought that would be kind of an optimal number of features to use. And then with the window length, we found that performance improved the shorter and shorter the window length we used. So we settled on a 400-second sample length. So that's only 40 data points at 0.1 hertz sampling. And it's interesting to look at some of the features that were most valuable in discriminating SDs from negative samples, since they correspond to known features of the SD waveforms. So for instance, here are two positive and two negative samples, 400-second samples that were used. And one of the measures that was, one of the features that was selected was the rate of mean crossing. So that the mean value here is the dashed line. And you can appreciate that the SDs cross that mean value 3 to 4 times, as opposed to these negative cases where you typically only have one crossing. And so here's violin plots of the population data of all the samples used, showing the higher mean crossing rate on average for positive samples compared to negative. And then the same is true for all the other features. This is the peak amplitude. Obviously, there's a large negative DC shift, so resulting in higher amplitudes for the positive samples than for the negative. And then skewness as well. There's a greater degree of negative skewness for the distribution of voltage values, of the 40 voltage values for SD positive compared to SD negative. There's also differences in just the simple mean of the sample due to that negative skewing of values for SD positive cases. So we're really taking the very simplest features that can easily be appreciated and understood by a manual scorer. And using those, and though no one of those features is completely discriminating, or even really a great, even a modest discriminator, when you put 30 of those features together, you get pretty good, pretty reliable discrimination. So while we had good results, the method was only discriminating between single snapshots in time, essentially generating a single probability value that particular static image was in XD. But what about the next snapshot? Is that in SD too? So we really had to adapt the algorithm to operate on continuous data. And we did this by computing probabilities for each incremental time advance to generate a probability of SD time series. And then once we did that, we had to then develop criteria to decide which spikes in this curve would be considered SDs. In other words, what duration of probability of SD elevation at what level is optimal for SD detection performance? And so we answered this question empirically by simply varying the duration of the duration threshold and the amplitude threshold for the probability in different combinations, and again assess the results with the F1 score, generating these types of contour maps, which end up showing a pretty broad ridge line across this parameter space, where we get near optimal performance. So, for instance, if you slide down this hillside up in the top right corner, you're getting too few true positive detections. If you slide down here, you're getting way too many false positives. So the optimal balance is somewhere here in the middle, and we ended up settling on parameter values of thresholds of 0.5 probability and 50 seconds of duration to decide, yes, this is an SD, or no, it's not. And so this is just an example of this continuous time series application in action. So the blue traces here are the ECOG from 3 different channels of a patient. And the gray is the probability time series, and the red dashes here are the automated detections. So you can see here in channel 2, the automated detection is just perfect. These were pretty easy SDs to detect. Down here in channel 4, the algorithm also correctly detected this event and this event, so 2 of these. But it failed to detect these 2 events. You can see the probability values here are just not quite elevated enough for a long enough duration to pass that, surpass our thresholds. So these were 2 examples of false negatives. And then here in channel 5, this was kind of interesting because there were 2 machine detected events, but these were actually not scored as ground truth positives in the manual scoring. So that was pretty interesting. So they're technically false positives, but let's put a question mark behind it for now. So using the 400-second windows and the 30 features and the thresholds that I just mentioned, we then tested the performance of the algorithm on a naive cohort. And this was a cohort of 11 patients, 1,100 hours, with more than 1,900 ground truth positive events. And what we found in the test cohort was that the rate of true positive detection was 64%. And that compared to a 71% rate in the training cohort. So that was pretty good preservation of performance, only a slight deterioration compared to the training cohort that we were really pretty pleased with. And then the false positives, in the test cohort, we had on average 6.5 false positive detections per day. Now and remember, that's per day of 6-channel recording. So that's like per 6 days of single channel recording. And again, that was only slightly worse than what we saw in the training cohort. And we wanted to better understand the limitations and look at improvement of the algorithm. We went and examined in more detail, what were these false positives? What is the machine thinking that are SDs that aren't really in fact? So we looked at these in more detail, these 323 false positive events. When we manually reviewed each of these events, we found that, in fact, 99 of them were nothing resembling SD. They were definitely false positives that the algorithm should not have detected. However, the remaining all fell along this spectrum of, yeah, that's definitely an SD, or oh, pretty sure that's an SD. You know, maybe there's something that gives me a little bit of doubt, but or that could very well possibly be SD, but maybe these events just weren't counted in manual scoring because it was inherently very conservative in identifying only those things that we were certain about. So it turns out the vast majority of the so-called false positives are in fact probably true positives. And just to give you some examples to allay fears that I might be cheating or fudging this, this is one of the examples where there's a clear SD in the red channel propagating to the green channel and then to the purple channel. And we see this occasionally, that there are sort of these double hump SDs. And this is a phenomenon that we don't really understand. We know that SDs can't really repeat more often than every 10 minutes. But here we get these double humps with a second sort of afterthought SD occurring in the wake of the initial one, typically 2 to 3 to 5 minutes later. And we just don't score these manually. We don't count that as a second one. But the algorithm didn't know that, so it picks them up. And these are definitely a real biological phenomenon that is an SD. So these are two of the examples of false positives that are, in fact, really true positives, just depending on what your scoring convention is. And here's another example of true positive SDs that were detected here in orange and red, and then on to green and then to purple. But again, here in this red channel, we see this sort of double hump phenomenon where the machine again picked up this as a second SD. But the human score did not score that. Another example here is when another SD recurs here and runs into an artifact that's affecting all these 4 channels, as indicated by these white arrows. And the human score just simply didn't score these because there was artifact interference and it wasn't, just 100% clear. But in all likelihood, this is a real SD on right here in the yellow, then in the red, and the other 2 yellows. So the algorithm was picking this up, and these types of events are what counted for most of the false positives. So if we could, just have this put an asterisk behind this 323, or and revise it down to an actual rate of around 99, or two false positives per day, once we make that adjustment for these likely SDs. And it's important to emphasize also that these are not just cumulative results, but they also applied, the performance was obtained across pretty much all subjects. So it wasn't the case that some subjects just did really badly and some of them just did really good. In fact, it was pretty uniform across all the 9 test subjects. So the true positive rates are 60, 72%, 83%, 55, 63. There was only one that had kind of a poor performance at 26%. And the same is true for the false positives. I mean, the rates here were low across the board, with only one being slightly elevated at 5.9 events per day. So we also are interested to look into the false negative cases to better understand, why some of these events are not being picked up by the algorithm. And what we did is take all those cases and cluster them and force them into 5 clusters. And you can pretty clearly see a couple explanations for why these were not being detected by the algorithm, because they differ in characteristic ways from the typical SD event. In one way they differ is just by having a very shallow amplitude, just a negative deflection of 1 to 2 millivolts as opposed to 6 or 7 millivolts on average. Secondly, they tended to have these large positive after potentials, which you can see in cluster 1 here and also here in cluster 4. And then a third typical reason is just that these were oftentimes very prolonged SDs. The algorithm had difficulty detecting SDs that have very long negative DC shifts. And here are a couple examples of that. Again, these divisions are five minutes apart. So this SD has a negative DC shift of 10 minutes or so. And so does this one. These were both false negatives that the algorithm did not detect. And then same case down here below from a different patient, about a 10-minute long event and a 5-minute long event, which the algorithm did not detect. By contrast, the typical SD negative shift duration is about 2 minutes. So when you get up to 5 minutes, 10 minutes duration, we get some more false negatives. Here's another false negative due to artifact interference. Here's an example of a false negative due to a very shallow amplitude and slightly atypical or anomalous waveform that started going positive before going negative. And then here's one of those typical examples of a shallow negativity followed by a really large and prolonged positivity. So one of the things that I found interesting about this project was really having the opportunity to review every single trace of ECOG to decide on whether each individual wiggle was an SD or not. This hasn't really been done before, to my knowledge, and it highlighted for me the heterogeneity of these signals in a way that I hadn't really appreciated before. And really forced me to explore the frontier of what is certain and what is not certain about what is an SD, because we typically don't make judgments on every channel and every single trace. So what we found is that automated scoring is not as good at finding the routine SDs, about 30% miss rate as far as recognizing true positives, but it is less conservative and more objective in calling the edge cases. So overall, I think this holds tremendous promise as a tool for real-time monitoring and clinical action, not as a replacement, but as a supplement to manual review. And I think it's significant and surprising that only minimal data is needed for SD detection. And I think this work kind of sets the floor level for accurate SD detection, because even though we have a modest false negative rate of 36% in detecting all SDs, this will be compensated by occurrence of the same waves on adjacent channels, which provides some redundancy and allows for some room for error. So our next step will be to begin developing rules and methods to group the individual waveforms, the events, into the super events, that is, counting unique SD waves. We can also begin to look at the use of depression periods to enhance detection accuracy. We can look to recognize and label the subgroup of isoelectric SDs, considering their prognostic significance. And we can continue to refine and validate these methods in additional patient cohorts. And just to finally close off here with to illustrate what I mean by this super event grouping, in counting the number of unique SD waves across the strip, as has been our standard practice for 20 years. What's shown here is raster plots for the 6 channels of the time of manually scored SDs in each of the 3 channels. And so you can see one SD wave occurring here and then recurring in a second. And these are, again, labeled SD1, SD2, SD3. So we count a total of 12 unique SD waves here. If we look at the same segment according to the manually scored events, I'm sorry, the machine scored events, we see pretty much the same pattern, and we can develop a rule for the algorithm to group these into super events, and we end up getting the exact same count of 12 unique SD waves across the strip. And note that we can get this even though the automated algorithm missed all of these 6 events in channel 4. But again, there's redundancy in the data across different channels because every channel is an opportunity to catch the same wave. So just because one of the channels didn't catch it, or the algorithm didn't catch it, we still have the information that a wave occurred from channel 5 and channel 6. So that's what I refer to as redundancy of information. And allows for a little bit of an error rate. It provides some forgiveness to the algorithm. Appropriate analogy for Good Friday. So, and here's just another event where this is the manually scored raster plot. And we have a super event count here of 7 unique SD waves. And again, this is the machine learning, the particular events detected that were grouped into, again, 7 different unique waves. So again, the algorithm got the count right, even though when you look at the individual events that it detected, it actually looks pretty different than the manually scored ground truth. A lot of the dots don't line up between one and the other. The machine learning found one here on channel 2 that wasn't existent in the manual scoring, et cetera, et cetera. But you will notice that it got everything right on channel 5. So again, there's a lot of room for error to get the overall picture right with the machine learning, with the automated algorithm. And so we've done this and assessed the super event counting across a cohort of patients, and these are the summary results that we've achieved so far. And so what this is showing is the ground truth count of number of unique SD waves across 4-hour chunks of data, again, manually scored, versus what the automated scoring came up with. And we see a very close correspondence with an R-squared value of 0.9. So I think that is really encouraging for us to continue this work, and encouraging of the idea that this could be very clinically useful in distinguishing patients who are not having SDs, having a little, having a lot, and identifying particularly the timing of when those transitions occur. So let me finally just make an announcement and help spread the word about the next international conference on spreading depolarizations that's going to be hosted near London in Windsor, which is very close to Heathrow Airport, 10 or 15 minutes, at the the Beaumont Estate at Old Windsor, which looks quite beautiful. That's going to be held on December 8th to 11th. This is the annual meeting of the COSBID group, addressing translational research from bench to bedside on spreading depolarizations and related topics. So please save the date, put it in your calendar and keep your eyes out for an announcement about registration and call for abstracts. So thank you very much. And let me just also acknowledge Ethan Mushnick, who's was a student who worked on in developing the software that generated a lot of these beautiful images that I shared today. So Ethan's a bright guy, very grateful for his work and very grateful for my clinical rock star colleagues, Laura and Brandon, who assist in all this work. And I think we can take some questions, or I'll turn it over to Moberg. We also have Sreekar Puchala, who did all the work. He's on the line as well to help answer any questions.
Sure. Yeah. Thank you so much. What a fascinating talk. These SDs have been so interesting to learn about for me. I hosted one of the webinars, one of our previous episodes. I think we have some of those people in attendance here, where we talked about non-invasive detection of cortical spreading depolarizations. I had just a couple questions for myself, and then I'll give some people time to write their questions in the chat. I thought it was really interesting, just first of all, how the false positives ended up kind of being true positives. And with somebody as a machine learning background, that's sort of just a testament to supervised learning about how sometimes the labeling is wrong or missing, or human labeling could have errors or just not be possible. And I think it's funny because I've actually used that effect as a strategy to clean data sets in the past.
Yeah, that's very true. I mean, and yeah, that's what a lot of the work in this has gone into, is going back and discussing, well, what is the ground truth? Is there such a thing as ground truth? Because, there are limits to human knowledge too. So how do you handle those cases? Yeah, it kind of speaks to again, how we were sort of touching the frontier of what we actually know and what we don't know, because no one's tried to go and make decisions based on the channels that don't look so good or they look atypical, because the human score just goes to the channels that look good, and that are easy to read. So we really had to push the edge of our understanding here.
Yeah, absolutely. And in terms of how the data was prepared for supervised learning, either you or Srikar can maybe answer this question. But it seemed like with the 40 data points over 400 seconds, it seems like the amplitude or the DC offset was a large factor in the classification. And it made me think, if we have these SD waves that are different lengths and potentially different amplitudes, um, is there a way to sort of normalize those in the supervised learning training process? Or did you embrace variation in all of those features to train the model?
I'll let Shrikar address that, because I know we did test that idea of trying to normalize things. Are you with us, Shrikar?
Maybe I can. Let me see. Yeah, I see Srikar in the participants. Either you can type the answer in the chat or you can turn on your voice.
Sure, yeah. So we decided not to normalize the data, just not to lose the information from amplitudes. But yeah, we could try doing that as well. We have some experiments done with normalization as well. We just
Yeah,
sort of not doing the normalization. So
it made me think of the I can't remember if it was a false positive or false negative case where the amplitude was low. And that just got me thinking, what about amplitude normalization? And so it's good that you had thought about that.
Yeah, we did. I think the problem with that is that you normalize, you make a lot of noise look like SDs.
That's true.
That's the predominant effect.
Sure. Okay. Yeah, I'd really love to see this algorithm generalize across a large cohort. I know we had there's some difficulties with getting ECOG recordings, especially to the nature of, breaking open the skull, putting on the strip. But I'd really love to see a diverse cohort of patients, um, and seeing this analysis again on them. Do you have any plans for that?
Yes, we have a couple more cohorts lined up for that we're saving as our naives for and we'll be using them for future testing and validation. Yep. But
Awesome.
it would be great to, I mean, there is, as I mentioned, there really is no large shared database, public database available sort of between centers. But that it's an idea that always comes up, but no one's really organized to collect or establish that yet.
Sure. I'm going to turn to the chat now for questions. One question from the chat. Are there any other neurophysiological events that happen with the presence of SD so that you can feed into the model? Things like cerebral blood flow, oxygenation, or metabolism. I guess that makes sense. We're just detecting the SDs with the electrocorticography signals, but is there any neurophysiological events that happen with the presence of SD that you could put into the model?
Yeah, there are. I don't think that they're going to give you. I mean, that's really SD prediction at that point, rather than detection. And we've done some multivariate modeling of those different neurocritical care variables, PCO2 levels, ICP, blood pressure, temperature, to see if we could predict when SDs occur. And you can do that reasonably well. But it's a lot more coarse than in the time course, and less precise in the accuracy than what we're doing here. But yeah, those models are being developed. I think people are interested in doing that, and the work we did on it was all really predicting things on an hourly basis. But it would be super interesting to take the next step in that and use continuous data to more precisely predict and model the timing of occurrence of SDs.
Yeah, that's really cool.
Mm-hmm.
Just to follow up on that, another question from the chat. From your clinical decision making, how critical is it to have a strip electrode? And what are your thoughts on depth electrodes?
Well, we did do a study of depth electrodes, and I think collected about 40 patients, and we required that they always be placed in the ipsilateral to the lesion site, the primary lesion. There were only about 5 patients out of those 40 where we detected SDs. So the hit rate was not very high. Now, those were non-surgical patients, other than the placement of the bolt and the invasive probes. So whether that difference in incidence of, I don't know, what was it, 12% with depth electrodes versus 60% incidence in patients with strips, is that due to differences in surgical versus non-surgical patients and the degree of their injuries, or was it due to failure of detection by the depth electrode? I suspect that it's failure of detection due to the depth electrodes, because you're only monitoring a single point in space.
Interesting. Yeah.
That's opinion, that's not fact, but that's my strong feeling.
Well, thank you for providing your feeling. I'm gonna take the slides just for a moment here. Oh, I do want to plug our previous episode. If you were interested in the non-invasive wavefront SD detection, we do have a previous episode on our YouTube channel. You can go to our website to find that previous episode and watch it for yourself. And really quickly, I do want to demonstrate that in the Moberg platform, we do have an integration for the SD detection from University of Cincinnati. We have not as pretty looking of a display, but we have our prototype implementation. Here we see the ECOG, and if we turn on automatic SD detection, we can identify these events are occurring. Another algorithm that we have implemented into our system is COIN, the correlate of injury to the nervous system. This is a novel qualitative EEG index to detect stroke and cerebral ischemia. This aims to do sort of the same thing as the automatic SD detection, which is to bring the detection into the hands of non-experts. So, for example, reading the electrocorticography signals may require a lot of training and a lot of practice. And COIN tries to do the same thing for stroke and cerebral ischemia. To detect stroke, we've involved this into our Moberg platform. And you can see the EEG on top and the COIN value below. We also have persist integration. Not sure why the screenshot didn't show up. But we have also an integration with CPP-opt and MAP-opt, and that gets into some of my own research. Sorry, the images are not showing up. But that's all right. I'll just skip over that. Of course, thank you to everybody for tuning in. If you want to stay up to date with the latest from Moberg Analytics, subscribe to our newsletter, the Neuroscience Monitor, and find us on social media. And thank you so much, Dr. Jed Hartings, for being with us today. And we'll see you guys next month.
Thanks, Justin.
Of course. Have a great rest of your day, guys. Enjoy your weekend.